It is truly an honor and pleasure to introduce this year's President of the Congress of Neurological Surgeons. This won't be the typical introduction. Besides sharing with you the accolades of Dr. Rodts, my task today is to tell you about the person of Dr. Rodts. We can look up his CV, we can look at his books, we can read his chapters, but what about the person that I know that you don't know can I share today? This first slide illustrates Rusty. I first met Rusty in 1990, 1991. I was in the Air Force and interviewing for a job at UCLA. We had carousels back then, and Rusty was in the lab and found a carousel. We talked about our love of baseball. We both caught. I was mediocre, he was phenomenal. We both liked spine. I was mediocre, he was phenomenal. And this friendship has burgeoned over the years where we're like brothers. I know his family. Our kids grew up together. Our dads and moms know each other. In the upper left is Rusty the surgeon. Bottom left, Rusty the athlete. In the right is Rusty the academician. And the academician is really one of service, which we'll talk about in a minute. And the second is education of residents. The top is Rusty, who wishes he were a member of the New York Yankees, and the hope that his son Duncan will be a member of the New York Yankees. The last CNS Quarterly, different famous neurosurgeons were asked to talk about life after neurosurgery or their avocations. Rusty gave the intro message. And I think for those of you that read this message, you now understood what he's like. It's self-deprecating. It's humorous. You won't find one sentence with the word me. You won't find one sentence with the word mine. He won't talk about his success without humor and grace. And that is truly what separates him apart in the world of neurosurgery. Now, Rusty was born in Wichita, Kansas, July 18th, 1961, the son of the Midwest. He was born to Henny and Jerry Rodts, who I call family. And he was the oldest of four siblings: Avery, Shannon, Constance, who I can actually call Connie, and her nephews call her Aunt Con, and Mom Henny. He and his brother Avery were very close growing up. And you can see in the one picture is Rusty's dad, Jerry, with his Princeton blazer on. From his dad, Rusty inherited his love of fine sports coat attire and his love of Princeton. Now, he had early confusion with spine implants and brain surgery early on. He wanted to be a brain surgeon, but he got confused about where to place the metal. He was a fashionista. In fact, on the left were his early Princeton clothes, and on the right, his clothes that he later wore in UCLA in the 1980s. Again, he picked up the style from his dad. He graduated New Canaan High School in 1979. He was first state baseball catcher. He was first string catcher, Connecticut, New York, New Jersey, recruited by some pro teams. Several colleges came after Rusty, but he followed in his dad's footsteps and matriculated at Princeton University, where he starred on the University of Princeton baseball team. Beside baseball, he's played rugby, football, and several other sports, which we'll talk about in just a second. He later went to Columbia Medical School, where he finished. And when you ask Rusty, why'd you become a doctor? It's much like what Dan Barrow said today. It's your family. I happen to know Dan's father, Warren, had dinner with them. And if you look at the similarities, they're both middle-class families, excellent parents. Both of their fathers instilled a work ethic. And from Rusty's grandfather and Dan's dad, they inherited the love of medicine and the integrity that comes with being a physician. Rusty's grandfather taught him, never forget that it is a great privilege to be a physician. And thus, Rusty pursued the art of neurosurgery. Now, what very few people here know today, and I just happen to know because I'm a member of the family, is that prior to neurosurgery, Rusty tried his hand at several other things. He's just too humble to tell us. So before neurosurgery, there were the swimsuit model years. And before Dos Equis, he was the original most interesting man in the world. He doubled for Robert Redford in the movie All the President's Men. And he co-starred with Barbara Streisand in The Way We Were. He was a professional surfer in Hermosa Beach, but I've never seen a photo of Rusty on the surfboard. He tried his hand as a fly fishing guide, but if you can see by the size of the fish, that did not work. So he had to fall back up on his academic pedigree. Now, Penfield went to Princeton, and I don't know, there are very few people in this room, as successful as we are, who can match this. Princeton, Columbia College of Physicians and Surgeons, UCLA under Don Becker, Neil Martin, and Rick Badstorff. I was fortunate enough to train him at Emory as a spine fellow. Dan was smart enough to hire him on. He now directs the Spinal Fellowship Program and is professor of neurosurgery and orthopedics. He has 64 peer-reviewed articles, 17 book chapters, 2 patents dealing with posterior lumbar interbody fusion techniques. Beside that, he's had a tremendous impact on the peak cervical spacers that we all use every single day. He's directed 17 courses, taught at a bunch of faculty presentations, has given 125 presentations, has been invited around the world and throughout this country at universities and organizations. Now, there's a legacy of CNS presidents, and these 2 guys here I've had the honor to work with. Now, people reach the apex of academic neurosurgery and political neurosurgery for several reasons. Let me tell you about these guys, the honored guest and the president. They work like dogs. They have a work ethic. They have integrity. And if you look at this, what we are, we're neurosurgeons. And I can tell you, these 2 men can operate. They're surgeons. And that's what binds us together. I would be remiss without mentioning the 3rd triumvirate of Emory, and Congress presidents, Nelson Oisiku, his wife Lola. Nelson is editor of your peer-reviewed journal, Neurosurgery. Again, Nelson has probably more integrity of any man I've ever met and has also mentored Rusty. Now, Rusty's told me for years how hard they work at the CNS executive meetings. We can see here with the Kanziokas, Mrs. Oisiku, and Molly Winston Barrow, the husband of Dan, their hard work. It's also clear that there's perks with becoming a president. You can get old and bald like Dr. Hadley, and the women still clamor around you. Unfortunately, I don't have that acclaim. You may think Rusty was serendipitous in becoming CNS president. Actually, this started years ago when he and Dave Adelson planned for this. This is Dr. Adelson before PX90. Why is Rusty president of the Congress? It's really simple. It's work and it's service. And I've watched him for years toil away to service all of us. He is tireless. Beside president this year, he's been vice president, secretary, scientific program chair, meeting chair, member at large, ex officio. And I'm not going to read this off. I think this speaks for himself. Speaks for itself. He has worked tirelessly for this organization, for me and for you. He's been on the editorial boards of Neurosurgery, Spinal Surgery, Journal of Spinal Disorders and Techniques, and Neurosurgical Focus. He's been chairman of the spine section, president of the Georgia Neurosurgical Society. He tells me he once hit a baseball 420 feet over center field. That's an accomplishment few here can boast of. Rusty is in a old man's league in baseball. He's telling me he's throwing a slow curve. If you look at sort of a lob, he's rotating his hand. And this is the only photograph I could find of Rusty as a Princeton tagger, where he was literally a star catcher. Now, if you look at this, look very carefully. He's transferred his weight, hips have pivoted, it's opened up, his shoulders have released, full arm extension, the wrists are cocked, and look right above the catcher's mitt. That's where the ball is. Now, Rusty's grandfather was a scratch golfer. Unfortunately, Rusty takes golf from his father, Jerry. Rusty and his dad would come down every spring training to my folks' house at Vero Beach, and we go to the Dodgers games and play golf in the afternoon. This is par 5, number 15, Intercoastal Waterway. Rusty always bought a lot of balls. Rusty trained with some phenomenal guys at UCLA. and he's trained men and women at Emory. And all of us here at Neurosurgery understand the dedication and the rigor it takes to become a neurosurgeon. Brian Subach, one of our former fellows, presented this to us. It talks about the band of brothers. From this day to the ending of the world, but we in it shall be remembered. We few, we happy few, we band of brothers. For he today that sheds his blood with me shall be my brother, be he ne'er so vile. Rusty has a lot of brothers. Duncan McBride, who Rusty named one of his sons after, Todd Landman, Ian Kalfas, Joe Alexander, and Jerry, who's no longer with us. Here he is playing golf with former CNS Presidents Dan Barrow, Mark Hadley, Hunt Bacher. He and Dan are going to smoke a celebratory guitar after this meeting is over. And that's Rusty and I in Alaska on my 40th birthday. Family is absolute paramount to all of us. Because when we go home at the end of the day, we need a respite, a sanctuary. Rusty goes to his son's schools, that's Brady in the lower left, to teach him at Dr. Day. His sons, Duncan, Teddy, Brady, his parents are still supportive. His beautiful daughter, Lane, who I'm blessed to be the godfather of, have given him sheer delight. But there have been other times as well. Here's Rusty and Kelly, the love of his life. The boys, who are now taller than me, surfing, and Brady fishing, and again, Rusty and his dad playing golf with my father. But family's not perfect. Family is like having a bowling alley installed in your brain. This is Rusty during his fellowship on a Friday night coming home for a cold drink. And he follows my rule, which is the martini rule. Always have one less martini than your number of children. If you look there are 3 boys and 2 martinis. Rusty's expecting his 5th child. I think he has an ulterior motive. Again, the glue that holds it together for Rusty and the boys and his daughter is Kelly. She's phenomenal. So today I'd like to introduce to you a world-renowned brain surgeon, an international man of mystery who has conquered the art of neurosurgery by commitment, passion that's mixed with compassion, and balance. Rusty came into San Francisco a few days early. I called him over the phone and left a message. Congratulations, I'm proud of you. And he sent back an email, and he does not know I'm going to show this. This is Rusty's email to me from 11 o'clock one night a few days ago. I know you know me well. When you give the intro, know that what means the most to me in my career is taking great care of patients, having good judgment, doing good technical and appropriate surgery, and teaching others the same. I'll never win any scientific prizes, and God knows I hate to write science, but helping develop the skills and knowledge of residents and fellows has been very meaningful to me. That's been my thing, and that's his capitalization. The other thing that means a lot to me is the fortune to have been able to work and interact with such an amazing group of talented, dynamic, fun colleagues in the world of spine. I owe them all the great debt for all that I've learned. And so today, besides telling you all the accolades about Rusty, I'm going to tell you about the person of Rusty, because that's where the value truly lies. And Rusty lives this quote. He lives it. In dwelling, he lives close to the ground. In thinking, he keeps to the simple. In conflict, he's fair and generous. He doesn't control, and he's very present in his family life. That's quite an accomplishment. Rusty and I also share this, that when a man travels the world in search of what he needs and returns home to find it. Ladies and gentlemen, I'd like to introduce the 2010 President of the Congress of Neurological Surgeons, Gerald Rusty Rhodes.
Thank you, Reg, for that very generous introduction. Thank you, Mr. Annual Meeting Chairman, Mr. Scientific Program Chairman, presiding officers and moderators, colleagues and friends. It is truly a great honor to stand before you today. I'm excited to have my parents, Jerry and Henny, here, my wife, Kelly, sons, Teddy, Duncan, and Brady. Their baby sister, Lane, is in the midst of her terrible twos, and she is in an extended timeout back in Atlanta. My wonderful sisters, Shannon and Constance, are here, as well as my cousin, Brun Hilbert. James Edmonds, the most dependable and compassionate nurse a neurosurgeon could ever dream of working with, is also here with me today. I thank all of you for your unending support. Kelly, your incredible patience and love and support are the key to the happiness of our family, and I am forever grateful. You are a saint and my angel. It was over 2.5 years ago that I learned that I would have the opportunity to serve as president of the CNS. It dawned on me at that moment that the nominating committee and the CNS membership had finally figured out that there was one last job that would guarantee my permanent departure after 12 years. When one learns that they will have the opportunity to serve as president of the Congress of Neurological Surgeons, the immediate excitement of the moment is quickly subdued by the panic of wondering what to talk about for 30 minutes to one of the most talented and diverse groups on earth. For those of you who know me, you know that I would be most comfortable discussing the many delights of baseball, the strategy of the hit and run, the timely execution of a bunt, or the throwing of a curveball. Tossed in, of course, would be many grossly embellished stories of my own career. But for many of you friends, a repeat telling of those stories would likely be completely intolerable. And not all of you are necessarily baseball fans. So I'll close the book on baseball for now. There is one subject, however, that binds all of us together, and that is our passion for treating disorders of the spine. In the remaining time here this morning, I wish to briefly review with you the sputtering start of spine care and surgery dating back to ancient Egypt and Greece, through the medieval period, up to the meteoric development occurring in the past few decades. Though a comprehensive review is not possible in such short time, and though there are some well-known names I will need to leave out, I'd like to share with you some interesting highlights in the history of spine surgery. In recent decades, wise and forward-thinking leaders in neurosurgery realized the need to dramatically advance the education and training and science of spine surgery. The technological advances have been astonishing. But the remarkable success of the past decades have come with many challenges and roadblocks. Some pressures have been external, such as the federal government, the legal profession, the media, and even fellow physicians. Many problems are internal, having been created by ourselves. To ensure continued success and development of the field of spine surgery, everyone in this room needs to accept important responsibilities as individuals. Among the first medical writings ever discovered that describes the treatment of spinal disorders is an Egyptian papyrus from the mid-1800s BC. This papyrus was acquired by a shady relics dealer named Edwin Smith, for which it is still named, and was ultimately translated by Henry Breasted in 1930. The papyrus presented 48 medical cases, and 4 were related to brain and spine injuries. The Egyptians clearly understood the relationship between brain and spine injuries and their effect on the function of the body. Complete injuries were felt to be hopeless and were not treated. Incomplete injuries were treated with prostrate positioning and binding the area with fresh meat and then honey until recovery. More than 1,000 years later, the Alexandrian school was established in Greece. Cadaveric dissection and didactic teaching developed. War and other violent conflicts produced innumerable spinal injuries. Hippocrates advocated treatment of incomplete injuries with rack and gravity reduction and sudden violent jolting techniques known as succussion. If a patient was supine, a goat's bladder was filled with water and placed between the patient and the rack. External splinting was used to force spinal deformities into a normal position. Actual surgery was rare. Hippocrates realized the relationship between spinal injury and paralysis and urinary retention. The next great contributor to the advancement of spine care was Galen of Pergamon, who lived in the Roman eras of Antonius, Pius, and Marcus Aurelius between 129 and 200 AD. He was a forceful figure who adhered to the teachings of Hippocrates and the Alexandrian school. He was a physician to gladiators, so one can only imagine the horrific injuries he treated. Galen related the level of spinal cord injury with deficits. He was the first to use terms like scoliosis, lordosis, kyphosis. He advocated surgery for traumatic bone fragments affecting the brain and spine. Infection was felt to be a sign of good healing, hence the term laudable pus. Paul of Aegina was trained in the Alexandrian school in southeast Greece. He was the first to actually to propose surgery on the injured spine. He wrote an epitome of 7 books which summarized Galen traditions and Greek medical thought. Known as a skillful surgeon, he performed trephination for the compressed spinal cord with removal of bone fragments. Paul of Aegina developed numerous instruments, including one called the red-hot iron. One can only imagine its use without adequate anesthesia. After the fall of the Roman Empire, there were really no new ideas for a millennium. Avicenna of Baghdad was an important medical figure during the Arabic and Byzantine era, which lasted from AD 99 to 1037. His works were translated into Latin. He emphasized bedside teaching. His greatest work, Canon Medicini, contained a series of illustrations on how to reduce a spinal injury with distraction, as depicted in this illustration. Overall, however, he had a hopeless outlook on spinal injuries and did not support the concept of surgical intervention. There was a resurgence of Italy in the 1100s in Italy in the school of Salerno, led by Roger of Salerno. Roger was the first Italian, he produced the first Italian surgical text, Practice of Surgery, a book later owned, interestingly, by neurosurgeon Harvey Cushing. This medieval textbook dominated the field throughout Europe. Later, in AD 1205 to 1298, came Theodoric of Bologna and his textbook, Chirurgica de Theodoric. Theodoric outlined how to examine the spine-injured patient. He felt that pus hindered proper wound healing, and he promoted surgery using a wine antiseptic method which contradicted Galen and Avicenna. This was considered very controversial, and Theodoric was vilified by his peers. The early concept of aseptic surgery was not valued until Lister in the early 1900s. In order to assist the patient in tolerating the surgery, a soporific sponge soaked with opium, wine, hemlock, flax, lapithum, and mulberry was applied to the patient's nostrils. Theodoric's practice of trying to realign fracture dislocations by reduction and traction and to maintain correction with splinting is very similar to the management of spinal trauma today. The field of spine surgery continued to languish well into the 19th century. Nearly 1,500 years had gone by since Paul of Aegina introduced the role of laminectomy and removal of bone fragments, and surgery of the spine was still thought to be uniformly fatal. Scottish surgeon John Bell stated in 1820 that the cutting into a vertebra is a dream. His younger brother, Sir Charles Bell, also a physician, denounced laminectomy and the terrible pain it inflicted on the patient for only dismal results. Henry Klein performed what was called a trephination of the spine in 1814. He removed a fractured spinous process in a patient with complete paralysis and a thoracic fracture dislocation. The patient promptly died. He was severely criticized by his colleagues, and Klein's case alone seemed to sound the death knell for spinal surgery for the remainder of the 19th century. A lack of adequate pain relief drove surgeons to operate as fast as possible. With hurried surgery, poor techniques, bleeding, infection, sepsis, death, surgery of the spine was considered simply inhumane. The acceleration phase of spine surgery appears to have begun with Percival Pott's experience with tuberculous paravertebral abscesses, which was by far the most common source of spinal infection. In London, he reported good results to breeding those spinal infections. Other developments added to the momentum, such as Louis Pasteur's advances in bacteriology, Joseph Lister's concepts of antiseptic surgery, and Crawford Long's experience in Jefferson, Georgia in 1842 using ether anesthesia. On December 22, 1895, German physicist Wilhelm Röntgen took this medical x-ray of his wife's hand, and anterior-posterior spine images soon followed. American surgeon and pioneer Alban Gilpin Smith is thought to be the first to perform a successful laminectomy for trauma in Danville, Kentucky in 1829. This was the first successful report since Paul of Aegina 1,500 years earlier. The patient was a young man with progressive paraparesis over 2 years after falling from a horse. The spinous process and laminae were removed in the area of the injury, and the patient's neurological function improved. Victor Horsley is well known for his contributions to brain surgery, but he also had a significant impact on spine surgery. At Queen's Square, Horsley performed the first successful laminectomy and removal of a spinal cord tumor in 1887. For historical reference, this was the same year that Gottlieb Daimler introduced the world's first four-wheeled automobile, and the same year in which the professional baseball Detroit Wolverines defeated the St. Louis Browns in a 15-game multi-city World Series. In Horsley's surgery, antiseptic bone wax was used for hemostasis, as was deep anesthesia, and an extensive array of spinal instruments. The 43-year-old made a complete recovery. In 1895, Horsley presented a series of 7 patients that underwent laminectomy for either cervical tuberculosis or traumatic fracture. The one patient died. The remaining patients recovered well from that surgery, and he brought 4 of them to his lecture at the annual British Medical Association to attest to his success. Entering the 20th century, Pott's disease and associated deformity and traumatic injury remain the primary spinal pathologies treated by surgeons. Surgical debridement, as described by Pott, remained the mainstay of treatment until surgical stabilization techniques began to emerge. Posterior fusion techniques were greatly advanced by the contribution of Fred Albee, a New York City surgeon. Albee's famous monograph, Bone Graft Surgery, was published in 1915. Using a technique he described as akin to grafting fruit trees, Albee used sections of autologous tibial bone placed inside split spinous processes to fuse across the deformity of Pott's disease. He thought it was important to use the patient's own bone, or bone from a close relative, and he emphasized the need for decortication of important surface area. He understood biomechanical factors and Wolff's law, and often cited Murphy's beautifully simplistic but meaningful statement, the amount of growth in a bone depends on the need for it. The grainy image on your right is a lateral radiograph showing interspinous fusion. To put these advances into better historical perspective, this was the same year that President Woodrow Wilson watched the Boston Red Sox with Babe Ruth defeat the Philadelphia Phillies in the World Series, and the Model T was state-of-the-art in automobiles. It would still be many decades before the understanding and treatment of degenerative conditions of the spine would blossom. Though Mixter and Barr are often cited as the first to link lumbar disc herniation with sciatica, it was actually Walter Dandy who first reported 2 such cases 5 years before Mixter and Barr's landmark paper. He made a preoperative diagnosis of a spinal tumor using iodinated oil myelography. In both cases, he performed a transdural resection of the cartilage simulating tumor, with excellent relief of symptoms as a result. He proposed that the loose fragment of disc was related to trauma, and he had the great foresight to suggest that the trauma at onset is relatively trivial and perhaps repeated. I think most everyone in this audience would agree that one of the greatest figures in the treatment of degenerative conditions of the spine was Ralph Cloward. Cloward was the first practicing neurosurgeon in Hawaii, where he spent his entire career. As a volunteer civilian surgeon, he performed 40 craniotomies in the 4 days following the attack on Pearl Harbor, and he received a special commendation from President Roosevelt. He was a gifted surgeon. Cloward was the father of posterior lumbar interbody fusion, or PLIF. He first reported his work in 1943 at a local medical meeting in Hawaii, and then the Journal of Neurosurgery in 1953. His results with PLIF were excellent, but few could replicate his technical expertise until the 1980s, when technological advances made it possible for many surgeons. His anterior cervical procedure, published in 1958, was often criticized by staunch proponents of the traditional posterior Scoville techniques. Cloward argued that more pathology could be approached using the anterior technique compared with the 4 distinct posterior approaches. Reflecting on the criticism he often received, he remarked, "You can always tell a pioneer, he's the one with arrows in his back." For reference, in the year Cloward published his ACDF paper, the Chevy Impala was the hottest new car, and managers Casey Stengel, Yogi Berra, Mickey Mantle, and Whitey Ford led the Yankees to their 18th World Series title. In the decades that follow in the 20th century, development occurred at a dizzying speed. Discography was introduced. New anterior and posterolateral approaches emerged, such as the transoral, transsternal, costotransversectomy, and lateral extracavitary approaches, transperitoneal approach to the lumbar spine, and transthoracic approaches to the anterior thoracic spine. The science of biomechanics developed along with a better understanding of metallurgy and bone healing, setting the stage for better instrumentation. Up through the 1950s, treatment of scoliosis yielded poor results. Paul Harrington of Houston, Texas, devised a compression distraction hook and rod system that changed the face of scoliosis surgery. The basic concept was to lengthen the short or concave side of the deformity. Perhaps his greatest contribution was elucidating the principle of the race between the time to instrumentation failure and the time to successful fusion. The limitations of the Harrington system were that the construct had to be long, the hooks tended to dislodge, and it was designed for posterior approaches only. Sydney, Australia native A.F. Dwyer introduced a ventral instrumentation system in 1964, the same year in which the new Ford Mustang was unveiled at the World's Fair in New York, and the same year in which fearsome Bob Gibson and the St. Louis Cardinals mowed down the famous Yankees in the World Series. Dwyer's system could provide compression of the convex side of the curve, and it allowed for sparing of motion segments, shorter fusion. The early system consisted of screw cable, multi-segmented fixation, which distributed the load evenly over the scoliotic curve. The main disadvantage of the Dwyer system was that it was limited in axial loading and often allowed for progressive kyphosis to occur. It resisted tensile forces, but not shear forces. The pace of technology quickened rapidly in the 1960s, 70s, and 80s. Klaus Zielke replaced the cable of the Dwyer system with flexible rods, allowing for better control of sagittal balance. Eduardo Luque from Mexico introduced segmental fixation via sublaminar wires, L-shaped rods, and coupled cross-links. A quantum leap in posterior thoracolumbar instrumentation was made with the introduction of the Cottrell and Duboisset instrumentation from France. This was the first system to allow fixation of all three columns of the spine, using any combination of pedicle screws, hooks, rods, and cross-links. The CD system provided maximal rigidity to maintain coronal and sagittal plane balance. During this period, however, neurosurgeons contributed little to the advancement of the field. It wasn't until the 1980s that neurosurgeons began to increasingly utilize spinal instrumentation. In the cervical spine, more and more fractures are being treated by neurosurgeons with wiring techniques, lateral mass fixation, and anterior plating. Leaders such as Caspar, Cooper, Sontag, and Haid, and others led the charge. Trauma patients who had traditionally been treated in halo vests for months were instead fixated internally, put in a simpler brace, and more rapidly returned to life activities. Up to this point, neurosurgeons almost exclusively limited instrumentation to the cervical spine. When it came to the thoracic and lumbar spine, intense territorial battles emerged with our orthopedic colleagues, who felt that thoracolumbar instrumentation was their turf, alone. The Spine Task Force, assembled by the AANS and under the leadership of David Kelly in 1987, was instrumental in expanding the scope of spine surgery and education in our field. The goal was to teach neurosurgeons to treat the entire spine. In addition to producing guidelines for resident and fellow education, the task force emphasized that neurosurgeons should be trained to operate and instrument the entire spine. The American Board of Neurological Surgery confirmed that neurosurgeons had received training equivalent to orthopedic spine fellowship training. Similarly, the ABNS and Residency Review Committee amended their definitions of neurosurgery to emphasize the aspect of spine surgery and fusion with instrumentation. Many of you here today fought battles in your own hospital for privileges to do spinal instrumentation. Neurosurgical organizations pushed forward with new training courses, and the scientific programs of our meetings expanded to include more spine. The Joint Section on Disorders of the Spine and Peripheral Nerves was formed and held its first meeting in Greenleaf, Florida in 1985. The first spine practical course was held in 1987, at the CNS meeting in Baltimore. As Volker Sonntag points out in his excellent article on the development of spinal neurosurgery, the highlight of the course was learning how to twist 2 strands of 24-gauge wire 3 times per centimeter, a braided configuration that was easier to handle than 18-gauge wire when performing posterior cervical fusions. Thoracolumbar instrumentation, however, had started and remained within the domain of orthopedics. Many orthopedic surgeons fought fiercely to prevent neurosurgeons from placing instrumentation. On one occasion, I personally was the only neurosurgeon who attended a spinal instrumentation course put on by a very respected international orthopedic educational organization in 1994. At the meeting, I was singled out and told in front of the crowd that I didn't need to learn these techniques. I should always plan to simply perform the decompression and step aside. Frustrated and outnumbered, I packed up my bag with, of course, a few complimentary hotel postcards and travel bottles of shampoo and flew back home later the same day. We've come a long way from that era of hostility. An extremely important historical event that broke down the barriers between orthopedic surgeons and neurosurgeons was the pedicle screw litigation in the 1990s. Surgeons of both backgrounds united with spine implant corporations in their defense of pedicle screw technology. Ed Benzel recently pointed out to me the pertinent 19th century proverb that describes well this situation. Adversity can, indeed, odd bedfellows make. This was a hard-fat bottle, and ultimately, the victors were patients who were granted access to these tools via FDA approval or down classification. Certainly, this battle brought together our 2 fields. Orthopedic surgeons increasingly accepted that neurosurgeons were irreversibly entering the arena of complex spinal stabilization. Greater cross-fertilization took place in organizations such as the Spine Section, the North American Spine Society, the Scoliosis Research Society, the AANS, the CNS, and more. More emphasis was placed on spine in our existing neurosurgery journals. The Journal of Neurosurgery Spine was introduced in 1999. And through the efforts of the CNS and AANS and Spine Section, important guidelines were put together, summarizing our best medical evidence. Concurrent with this blossoming relationship between orthopedics and neurosurgery was an explosion in spinal implant technology and surgery. What then follows in the history of spine surgery is simply astonishing. And the main protagonist at the start of this story is a horse. George Bagby devised a cylindrical metal basket or cage to stabilize the degenerative discs in spines of horses that otherwise were destined to become paralyzed, a syndrome called Wobbler's syndrome. This concept caught the eye of inventors such as Michelson, Ray, and Kuslich, and their interbody cage explosion was on. The Ray cage and the BAK cage were approved in 1996 by the FDA. Soon there were dozens and dozens of different permutations of interbody cages, pedicle screws, thoracolumbar plates and rods in flavors of titanium, stainless steel, cobalt chromium, PEEK, and more. Cervical and lumbar disc arthroplasty has arrived, and advances in the biology of bone fusion have been tremendous. After almost 4 decades of research on the family of human bone morphogenetic proteins, the commercial availability of RhBMP2 has revolutionized certain spinal procedures. It has been an incredibly rewarding time to be a spine surgeon. But we also have created a cloud looming over us that must not be ignored. Coincident with the introduction of fusion cages in 1996, rates of spinal fusion rose in this country by 77% through 2001, according to Medicare data published by Weinstein and others in 2006. In contrast, hip and knee replacement increased 13% during the very same interval. Medicare spending for fusion increased more than 500% from 1992 to 2003. The spinal implant business back in 1994 was around $264 million per year. In 2008, spinal implant sales were over $7.45 billion, and the industry is expected to grow around 7% this year. Quite simply, the growth of fusion surgery in the implant market has been staggering. Despite clinical indications for fusion being relatively well defined in the medical literature and in the AANS CNS Joint Spine Guidelines, published in 2005, the indications in degenerative conditions has started to blur. Surgery has expanded beyond what is supported by the medical evidence. The rates of lumbar fusion are more variable across the United States than any other form of surgery, as demonstrated in this familiar map to most of you from the Weinstein's paper. And the clinical indications have become inconsistent. Findings of disc dehydration or degeneration at 3 or more levels in a patient without deformity and only back pain does not justify a 3 or 4 level fusion. Without any medical evidence to support such extensive fusions, it is unethical to perform them. Dr. James Robertson warned us early on in his 1993 article in Surgical Neurology, aptly titled, "The Rape of the Spine." Robertson expressed his concern and strong convictions about the growing number of lumbar fusions done for low back pain with ill-defined clinical and radiographic criteria. He stressed that we as surgeons, neurosurgeons, have a serious responsibility to put the patient first and to insist on participating in clinical studies to establish the indications for, demonstrate the efficacy of new procedures, and he called for a registry of complications with spinal instrumentation. We are all aware of surgeons in our communities that perform fusions in cases without instability or other acceptable indications, and who perform 3 or more level fusions for axial back pain, and who perform circumferential complex fusions in the elderly, despite the increased risks and morbidity and lack of proven benefit. Between 2002 and 2007, Medicare data demonstrated an increase in complex fusion procedures for spinal stenosis and a decrease in decompressive surgery and even simple fusions. We all have a responsibility in our own practices, in our own hospitals, and in our own communities to police ourselves. I urge you to challenge a partner or colleague directly when questionable indications or overly extensive surgeries are used. Critically review cases of excessive surgery at your hospital quality assurance rounds. We need to get the issue out in the open and discuss it openly and honestly at regional and national neurosurgery meetings. It can no longer be the 1,000-pound gorilla in the room that everyone is ignoring. We all need to make it a personal mission to call out those outliers who are threatening our ability to care for patients in the future with treatments that are supported by medical evidence. We know best the difference. The government and private insurers don't understand the difference. For example, private insurers in my own home state of Georgia have begun to deny payment for procedures that are well supported by the medical evidence, such as a 1-level fusion for grade 1 spondylolisthesis or a 1-level ALIF for isolated degenerative disease in the lumbar spine. If we don't eliminate the outliers, if we don't improve the medical evidence for our treatments, and if we don't improve our training process to better standardize the rates and indications for spinal surgery, the federal government and private insurers will certainly redefine how we care for patients. The challenges will come from several sources. In the Affordable Care Act passed by Congress and the Obama administration last March, a new Institute for Comparative Effectiveness Research called Patient-Centered Outcomes Research Institute has been established, and spine surgery will surely top the list of future studies. The new Independent Payment Advisory Board, IPAB, whose members will be entirely appointed by the President, will review Medicare expenditures and propose cuts. Spine surgery will certainly be targeted. The new public reporting of physician performance will begin in 2013, and this will include patient outcomes, resource utilization, and efficiency. We as surgeons, as individual practice groups and academic departments, must rise to the occasion and meet these challenges. The time has come for we as surgeons to take the lead in collecting outcomes data and to participate in comparative effectiveness research designed by surgeons, not federal bureaucrats. Some of our colleagues, such as the cardiothoracic surgeons, are way ahead of us. At this time, it is still unclear whether this would be best accomplished by neurosurgeons alone or whether we should combine with our orthopedic colleagues. The North American Spine Society recently held a meeting with all interested parties, surgeons, private insurers, employer groups, medical societies, policymakers, to discuss potential models to achieve this goal. NeuroPoint Alliance, NPA, is a new neurosurgical organization aimed at collecting outcomes data and performing comparative effectiveness research. It is made up entirely of individual neurosurgery practices. Though grant money has been obtained for the first trial project looking at lumbar degenerative disease, the cost of this type of effort will likely ultimately be borne by ourselves, practicing neurosurgeons. It will be important for all of us to make this commitment of time and money and effort in the near future in order to properly guide the ship of spine care through these treacherous waters. I urge you to follow communications coming to you by email and in the CNS Quarterly and the AANS Bulletin regarding these efforts. It soon will be essential to have the data that shows what we do for patients well and what is not effective. My last comments about the looming cloud we have created during this amazing evolution of spine surgery concerns physician-corporate relationships. We all have seen the attacks on physicians by our elected officials, agents of the Department of Justice, the Office of Inspector General, and the Court of Public Opinion laid out in the press. The inappropriate behavior of a few has endangered the future of surgeon-driven corporate technology development. Many highly ethical and creative surgeon designers have been vilified in the press, interrogated in U.S. Senate subcommittees, or have been the subject of frivolous lawsuits. As a result, many universities, including my own, have reacted in dramatic fashion to take away or limit the rights of physicians to consult and design with industry. This must stop. Products and tools that help make patients' lives better do not emerge for the market from inside the cubicle of a corporate engineer. Genuine surgeon ideas and input based on knowledge, training, and clinical experience are essential to the creative process. This relationship must be forever preserved, and I encourage all neurosurgeons with this talent and interest to fight this battle locally and nationally with passion and fortitude. It is an essential right as an American. The responsibility is upon us to do this in accordance with the very best business practices, with full disclosure and transparency, and with honesty. As we have reviewed, the sputtering start of spine surgery over the centuries has been followed by a meteoric rise in development just in even recent decades. Paul of Aegina would be stunned how effectively we treat the patient with a fracture dislocation. It is truly an exciting time to be alive and in the practice of spine surgery. I personally, and I'm sure many of you, feel very fortunate to have our careers coincide with this era of spine surgery. It has been exciting, it has been stimulating, it has been groundbreaking. It is important, therefore, to celebrate the work and accomplishments of those before us, on whose shoulders we now stand. In Cooperstown, New York, stands the Baseball Hall of Fame. There lie the busts of the greatest players of all time. Neurosurgery has its own list of superstars. These are the men who have laid the foundation for our field and to whom we owe a great debt. The Neurosurgery Spine Hall of Fame would likely begin with this original class of surgeons who have contributed so much to the development of spinal surgery and spine education. They provided national leadership and foresight at a critical time in our history. Ultimately, they helped us all provide better care of our spine patients. The door of the hall will next open to these neurosurgeons, whose ongoing productive careers as surgeons and educators and thought leaders have greatly advanced the field further. On their coattails are the next generation of men and women neurosurgeons who will help bring new, untold advances. It is a challenging time to be a neurosurgeon. We face many external challenges and pressures not seen in generations past. But we are all so fortunate to be able to intersect in the lives of those in need, debilitated by pain and loss of function, and be able to do good. In the words of my grandfather and physician who meant so much to me, Dr. Adolf Selman, never forget that it is a great privilege. Thank you.